Well, good evening, everyone, and welcome to the second of the JCU COVID-19 webinar series. Tonight, as you know, our focus is on mental health. Before starting with the content of the evening, I would like to acknowledge the traditional owners of the lands, the many lands on which we meet tonight, with webinars, of course, spread across much of the state of Queensland and beyond. We acknowledge the traditional owners of these lands and pay our respects to their elders past, present and emerging. So without further ado, if we could start the slides, please, Pamela, and we'll look at that first slide. Tonight we've got Brett McDermott and Wendy Lee. Very pleased to have them with us. For those of you online, you are automatically muted, so don't worry about that. Please, could you use the Q&A button at the bottom of your screen there if you've got any questions. We will give questions to the panel as we go along, as well as address some of the questions that have been submitted. Next slide, please. Very briefly, what we're going to look at tonight is evidence from 20 years of disaster mental health research, some of the risk factors and types of presentations and the impacts on both patients and responders, talk a bit about burnout and compassion fatigue, and then probably focus quite a bit on what's coming next, economic recession and the impact of that on mental health. We'll, as I say, just use your Q&A button at the bottom there, and without further ado, we will make a start. So next slide, please.
Okay, so thanks, Peta-Ann, for inviting me along, and thanks for everybody who have signed up. I assume that that you can hear me, so Peta-Ann, I can see you, not away. Good, thank you. Okay, so what I want to do is start and talk a little bit about disasters. Now, I'm talking about disasters because when you think about it, not only is the COVID-19 a disaster, but it has, I mean, everyone has been saying it's a journey, it's going to be a marathon. So what is actually that going to look like? Well, the only place in mental health research we know about the marathon is some of these major natural disasters that have happened. So this is a famous slide, Zunit and Myers, and I've been involved in 6 or 7 major disaster responses. This feels completely right to me. You have this pre-disaster phase where you kind of know the cyclone's coming or you know a bushfire's coming. You have this heroic phase where people pull together and societies do amazing things and they come together. And of course, as I speak, you can think of our COVID-19 response. I mean, Australians who are a somewhat, anti-establishment bunch at the best of times have all stayed inside. They've all socially distanced. They haven't whinged about not going to the pub. For Australia, this is heroic stuff, okay? There's this honeymoon where things are going well. There was a survey out today that said Australians' kind of feeling of happiness is the same now as 2 months before the pandemic. So people are doing very well. But after the active phase in disasters, there's this phase of disillusionment. And in Australia, natural disasters are always in summer. It's weird. In the north of Australia, it's a summer cyclone. In the south of Australia, it's a bushfire. And this disillusionment happens in the middle of the year, the mid-year blues. And people realise that the struggle is going to be much longer. The struggle is going to be more than they thought. The physical tiredness is setting in, the emotional tiredness is setting in, and things are starting to go wrong. Maybe the insurance is not being paid, maybe the bank's not refinancing. Maybe you thought the shop would be built quickly, but it's not. Again, we have some serious parallels here. I mean, we know that economic issues after this disaster, after the active infective stage, are going to be incredibly problematic. People are talking about, large, double-digit unemployment and worse than the GFC. And then there's this reconstruction phase. Now, the longer I work in disaster medicine, the longer this phase is getting. It used to be 6 months, and now it's thought to be 2 or 3 years. And in Victoria, after the last major bushfire disaster, 3 years after, there was still an increased rate of suicide. So the reconstruction phase is long. Next slide, please. And this is just to remind everybody that mental health, and one of the reasons I like mental health, it's wonderfully complex. This is a slide of child post-traumatic stress disorder after a cyclone. And we found that you needed to be exposed to the cyclone, obviously, but the major thing was threat perception. The major thing was, did you think you were going to die? Now, this has a direct relationship to COVID because, you know, people are telling me that a lot of people are going to get PTSD, and someone said to me that everyone's going to get PTSD, but they're actually not. You get post-traumatic stress disorder if you feel that you're going to die. And the highest I've ever seen was after the Grantham flood, and about 30% of people, you know, thought they were going to die. It's usually after natural disaster, about 10%. Now, of course, in some places in the world, obviously in the intensive cares of, you know, of New York, London, Madrid, Lombardy, Wuhan, these are obviously incredibly dangerous places for staff and for patients. And a lot of the people would be really fearful of death. They would have huge threat perception. We published one study that showed that if you thought you were going to die, your chance of getting PTSD was increased tenfold. You had 10 times increase of PTSD probability. So for a lot of places in the world, that actually might be what's going to happen. Australia, again, at the moment is a little bit different, and we'll talk about that in a minute. By the way, the other interesting thing about this slide, if you look at the bottom right, there's something called child connectedness. And what we found that social connectedness, being connected to other human beings, actually mitigated your feelings of threat. If you were high social connectedness, you were protected from PTSD. And if you were low, you had a 4 times increased chance. So again, these are complex models, but the really interesting thing is being socially connected to other human beings, like we are tonight on Zoom, is actually protective. And taking on the burden by yourself is truly worrying. If there are people involved tonight who are the principals of their general practice, or the principal of their accident emergency, or the head nurse of their organisation, etc., taking this on by yourself is ill-advised, by the way, and being socially connected is protective. Next slide, thanks. This is a little slide, and again, these are just really to remind me to talk to you about stuff. So this is slides after the Brisbane flood in 2010-11, and of course that was, well, actually the Queensland floods, and that was a pretty amazing disaster that, by the way, caused a lot of economic ramifications afterward. The top slide that shows that it didn't matter what social class you were, whether you were advantaged or disadvantaged or in between, everybody felt, 60 to 70% felt affected, often highly affected. And down the bottom, it didn't matter if you were from the city or the country or rural and remote, everybody felt affected, probably more in remote and regional. And I think that's also going to be the story for the virus in the acute, threat health stage, but also in the post-recession phase. This is actually going to affect everybody, and it might be affected as a worker, as a relative, as someone who's lost their livelihood. But there is a real sense that everyone's going to be in this together. I think this will have ramifications to all parts of society, and very few are going to be protected. Next slide. Okay, this is a little kind of, if you like, a little cartoon, a little graphic of what to expect. So the acute event, or the acute phase, which is now, if you have high levels of threat, you generally go down the path of post-traumatic stress disorder. And in question time, if people want to know more about these specific conditions, we can talk about that. But basically, if you're highly threatened, you go down the PTSD path. or the anxiety path. So GAD is generalized anxiety disorder, and another one's panic with agoraphobia or social phobia. So high levels of threat, you go down that path. Now you can get that, you can be completely emotionally robust and suddenly have a threatening event and go down that path. Or you can have long-standing anxiety and the acute event will make that worse. So there's two groups there. No one's particularly protected. The more threat, even if you're emotionally robust, if you feel like you are going to die, you can get PTSD. You know, Vietnam and every war has shown that. The other major acute path is grief and loss. It's a loss path. So, you know, if you lose loved ones, you can obviously have an acute depression or grief reaction. Now, the bottom one is kind of a chronic event, which doesn't quite make sense, but you know what I'm talking about, a chronic, ongoing, slow-moving disaster. Now, every Australian in the bush knows what that is, and that's the, you know, the incredible drought that many people have experienced. This was a chronic, low-grade, rolling-on disaster that had huge effects on society in the bush. We know that people develop chronic levels of hopelessness and despair. We know that there were endemic rates of depression with the drought in Australia, and we know that there were huge levels of suicide. In fact, they were so bad that organisations like Beyond Blue had a very specific, you know, rural remote suicide prevention strategy. Now, if you look at the literature, and the literature is really clear, Australians kind of possibly don't understand this, but in the global financial crisis, which Australia never had, by the way, we did not go into recession. But if you look at the literature on the GFC, in America, it's called the Great Recession, and in Spain, it's called the Great Recession, and it led to huge levels of unemployment and, you know, poverty and deprivation. And we know from the GFC literature that suicide rates markedly increased, depression markedly increased, and suicide went up, especially in unemployed males who were poorly educated. So education and unemployment were the main relationships with suicide in the GFC. Lots of literature about that. Look, I've also put under the chronic events, the other things that we need to be very mindful of, things like domestic violence, relationship breakup, and substance abuse disorders. So again, the GFC literature is really very clear that both in America and Europe, looking at large epidemiological studies across many countries, interestingly, the endemic rate of alcohol use did not change at all. They speculate because of lack of money, by the way, of a lot of people to buy alcohol, but the rate of binge drinking and acute intoxication markedly increased. And also the rate of domestic violence. And in fact, there's now 4 or 5 papers about non-accidental traumatic brain injury of children. And the rates again specifically increased in the GFC, in the 3 years post-GFC. So they are of great concern as well.
Brett, I wonder if I could pick up on that.
Please.
We've had some questions come in. So advice for clinicians working with patient populations who are at high risk of domestic violence, say, you know, alcohol, drug abuse, and so on. What advice would you have at this stage of how we can support family members best for patients who are currently affected by this?
Yeah, thanks, Peta-Ann. Now, of course, one of the great problems is that, you know, these are hard issues at the best of times. The obvious person to talk to is the person who's the violent individual. And the obvious thing to do is to try to get them to be mindful of this and mindful about the dangers of alcohol when they're under a whole range of other stresses. Of course, as you know, the most difficult person to talk to is the person who's the perpetrator of the violence, who will never come in and see you. And I try to have, you know, man-to-man conversations with, these folks. I've knocked at the door of some of these people, and they're very hard to actually talk to. I think we have to go back to things like risk mitigation. We have to go to very careful safety planning. I truly hope that the government, I think the government supporting incomes in this acute phase is going to, again, mitigate that acute phase despair, unemployment, impoverishedness, stress of the violent person. But after the acute phase, and when lockdown and relative lockdown has stopped, I think we have to do some serious safety planning. We have to be very wary of the potential of violence. We have to monitor, things like alcohol and drugs. By the way, other drugs went up as well as alcohol. So, I think we have to have very clear conversations about risk. I think we have to help our child protection organisations to understand that this is not business as usual. This is actually a much more risky situation. And when people are in those relationships and there is unemployment and, increased stress and poverty, I mean, the system actually has to function at a much better than it has traditionally. That's not criticism. We will just have to be mindful of these risks.
Thank you.
Next slide, thanks. So my last slide before we hand over to Wendy is again looking at that disaster slide, and I've just put a blue line and a red line on it, and I just wanted to kind of talk about this. Now the first thing is, and I've said to this to quite a lot of people at the moment, is I can say with incredible assuredness that I don't know what's going to happen. All right, I do not know what's going to happen, because at the moment Australia is doing remarkably well in terms of a low death rate, a low community transmission, and low numbers on ventilation. So if that continues, then we may not see the tragedy we're seeing in Italian New York hospitals. We might not see those acute stress events and PTSD, acute anxiety. I mean, everyone's going to be anxious. That's completely normal. But we may not see that acute PTSD and other events. Now, that does not get us out of the problem, because, of course, we have, we will have had 3 months of business making no income, and what is obviously going to be at least a recession. And there is some evidence about what governments do can highly mitigate what's going to happen. And I think that our government has protected the income of most people and made businesses the possibility that they'll stay viable, because one of their major resources are employees, obviously being their salaries are being paid. So it all depends. It all depends what happens in this phase of what is normally disillusionment, and also how quickly and meaningful we can return. The worst case scenario is obviously we have some serious issues around treating depression and being aware of the possibility of suicide and drug and alcohol problems. The best case scenario is that Australia can do what we did during the GFC and have a very, very soft landing, and we'll just have to wait and see. And I said to Peta-Ann before this talk, we might be talking again in 2 months' time. Maybe we won't need to talk to me in 2 months' time, and that would be a lovely thing.
No, I think we will. Brett, I've got a couple of contemporaneous questions that have come up, if you wouldn't mind just talking to them. So this one, when Brett refers to trauma, does he also include general social disorder / riots and so forth when the excess government money is withdrawn? So there's a
yeah. Well, again, Australia, Australia generally hasn't had the rich-poor divide that some countries in the world have had. And generally we have very low tradition of civil disobedience. I mean, I can think of civil disobedience I can think of one spectacular episode, which I won't mention, but generally we're not a country that does that. We're also not a country that has 380 million firearms held by 56 million people, by the way. So those things don't worry me too much. You know, we have been traditionally the lucky country in that way. And also we have, you know, we have a strong tradition of, you know, increasing taxes to fund what is going to be a difficult period. So I'm quietly confident we will not go down that path. But by the way, I think other countries are in huge danger. You know, there are countries
that's a real concern, isn't it, Brett? So just, yeah, thank you. Turning slightly is very different, and this is from a junior doctor who's currently doing a term in mental health, who observes that their hospital psychiatric team has undergone a complete restructure, where they've now got specific teams for high dependence, intermediate, and low risk ward. This doctor comments that whilst this is understandable, it has resulted in significant confusion and poor efficiency in managing patients. And they're wondering if you have any insight as to how other hospitals may have been restructured.
Yeah.
The response has been.
Yeah. So again, I'm just going to put on my generalist disaster hat here. And I think in the, you know, the great thing about disaster medicine in Australia is that we've actually been doing it, I think, reasonably well for, again, 20 or 30 years. And systems are, you know, like, for instance, I can look at the literature about what to do after a disaster, and incredibly narcissistic, I'll find a paper called McDermott and Cobham, What to Do After a Disaster. And it's quite useful, really. If you look how to run your psychiatric ward when there's a pandemic happen, you'll find, I suspect, no cognizance on that. And I think after disasters, what happened is there is a phase where people have to move very quickly, and they do things, you know, based on their best knowledge and based on, you know, trying to do the best. And over time, I think that system will become incredibly mature. We will find very quickly what other people's have done successfully, and that system will mature. So I entreat people that, you know, this is a crazy period of health. It will actually get better. And I think those processes will be streamlined. But, you know, I feel for the junior doctor making that comment, but also I've been on the other side of the coin. I really also feel for the service leaders trying to make sense of this terrible time. I think we all just have to be, you know, calm and kind for another month.
Thank you, Brett. Shall we move on to your slide, your first slide, Wendy? You'll have to unmute yourself.
Yeah. Thank you so much, Peta-Ann and Brett. Thank you, everyone, for coming to the presentation. And my presentation, because I'm a psychologist, so focus on quality of life, particularly refer to some of the studies Brett and myself have done in China in terms of professional quality of life, for example, burnout and secondary traumatic stress, and compare to those in Australia. And we talk about quality of life all the time, and WHO defines quality of life as an individual perception of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. This is the general quality of life, but for us working in healthcare system and healthcare field, there is another concept called professional quality of life. We all know as a healthcare practitioners, every day we face some positive perspective and aspects and also negative aspects. For example, we are proud of ourselves to help people. And so we achieve compassion, satisfaction, but particularly for many frontline nurses and doctors, we may experience compassion fatigue. For example, secondary traumatic stress and burnout. Next slide, please. And compassion satisfaction, I mentioned before, it refers to enjoyment of caring, sustained interest and motivation, and a sense of an accomplishment when we help people, help our patients. And on the other hand, we may also experience compassion fatigue caused by the repeat exposure to clinical related traumatic stressor. I think it's very obvious. This is something that many frontline doctors and nurses are experiencing when facing COVID-19. When we see the news and also read the newspaper and saw the videos on Facebook, we can sense how difficult for those frontline doctors and nurses. I will talk about that later using some examples from China. And secondary traumatic stress resulting from helping and wanting to help a traumatized and suffering patient. And burnout, we are very familiar with this concept, a state of physical, emotional, and mental exhaustion as a result of long-term involvement in mentally and emotionally demanding situation. I think burnout for those nurses and doctors, for example, in China, in Europe, in the US, we can see how the extension of burnout they are experiencing. Next slide, please. And this is the comparison, looking at anxiety, depression, compassion, satisfaction, burnout, and secondary traumatic stress between Australian nurses and Chinese doctors and nurses. The orange is the results of the study from the study we have myself and Brett involved in China. And the blue line was the Australian one. And we can see for anxiety, actually that's the mean score of anxiety among Chinese health workers are much higher than that in Australian nurses, and very similar in depression. But for compassion satisfaction, it seems Chinese doctors and nurses are less satisfied than their counterparts in Australia. And burnout and secondary traumatic stress, we can see that the mean scores of Chinese doctors and nurses are higher than Australian nurses, which means, from my understanding, for Chinese because I went to Chinese hospital as well, and I saw my family doctors in Australia. I feel that the workload and also the burnout among Chinese doctors and nurses are much higher than Australian nurses and doctor experience.
Sorry, Brett, did you have anything you wanted to comment here? I know when we were talking earlier, you pointed to the statistic of the sort of pre-COVID burnout levels of around 25%, which is pretty high.
Yeah, so thanks, Wendy. I mean, this is really interesting stuff. I mean, you know, to have a profession that has, you know, burnout of 23%, I think is truly worrying. And don't forget the Beyond Blue study of doctors and medical students showed that in the 12 months before the study, it's about 3 years old now, that 25% of Australian GPs had suicidal thoughts. 25% of Australian GPs had suicidal thoughts in the 12 months prior to that. So, you know, I think these are sobering statistics that you bring to the pandemic. And what I suspect is that Australian nurses and doctors will stand up admirably, but they'll stand up on the background of some of them being near burnout. And you know, that will not improve them. That will actually, you know, make things worse. Thanks, Wendy.
Yeah, absolutely agree with that. Facing pandemic, I think Australia is very lucky that our curve is flattening, but still is not as normal as before. So I think the burnout and also STS is much higher than the previous level. But it's very interesting that I reviewed the paper newly submitted to a journal. I was a reviewer. The paper looked at Chinese nursing working in the front line in Wuhan city, the pandemic center in China. Actually, their anxiety, depression, as well as burnout and STS, they personally feel that is less than previously, than the previous baseline. So I think it reflects to what Brett mentioned, the heroic stage, that because they were fighting together against the pandemic, the virus, they feel they are heroes. So the anxiety, depression level actually was lower than the baseline. So it's quite interesting. Next slide, please. And this is the result from our own paper looking at the mediation of burnout and STS and CS on the relationship between anxiety and depression. We all know anxiety, depression, very often goes hand in hand. Then for us as healthcare workers, what can we do to protect ourselves, particularly in such a difficult time? So when we look at, you don't need to look at all the stats. I just show you so that you understand. I'm a scientist. But you look at what I am highlighting, burnout and also compassion satisfaction. So we can see anxiety increase burnout, in turn increase depression. And anxiety results in lower compassion satisfaction, which in turn have a greater depression. So this is the relationship. If we look at the next slide, we look at how impression, the depression, the relationship between depression and anxiety mediated by STS. Combining two slides, we can see actually burnout, STS, as well as depression and anxiety, actually they work collectively, contributing to our mental health. So for us, I think during such a difficult time, to manage burnout and also manage the secondary traumatic stress and increase our compassion satisfaction will help us to better control depression and anxiety symptoms. Because we know when we are busy, we feel anxious. Everyone feels anxious in everyday life, but when we are extremely busy under the burnout circumstance, we may feel sometimes we have difficulty to breathe, and this is a symptom of anxiety. So I think we need to consider it in our everyday life. For example, taking deep breathing to try to calm ourselves down and focus on positive side of helping people may help us as well. Next slide, please. This is something I get from my friends who's a frontline healthcare worker in Wuhan, and as well as from some news. I think it reflects on the disaster stage Brett presented previously, and a couple of stages. For example, at the very beginning, burnout with long working hours and also lack of PPE. I think this is the case not only in Wuhan, but also we can see this is the case in many countries in Europe as well as in the US. And when the city was locked down, I think it was the first time that Wuhan city, the entire city was locked down, and health doctors and nurses, they feel worried, and also they fear what would happen. And after that, numerous support pouring into Wuhan. For example, 42,000 healthcare workers all over China joined the frontline healthcare workforce in Wuhan. So they feel they are cheered up, they're supported by many people, not only healthcare workers, but people all over the country. And also they feel they have someone to rely on, which creates a sense of safety for them.
So,
And
Wendy, can I just butt in there and say something about the Australian kind of healthcare system?
yes.
So, if Wendy, if you or I were looking at research now into this, I would say that people's perception of lack of PPE is going to increase their threat perception and make it much more likely that they'll get PTSD. So, for instance, we've been hearing, you know, that doctors feel shamed about wearing masks, and, you know, doctors are being encouraged not to use PPE. And the interesting thing about that is that obviously may or may not have an effect on their physical health. It may, of course, have a profound effect, but it actually has effect on the mental health. It actually makes them more likely to get things like, you know, anxiety and PTSD. So I think there's, you know, some really interesting things about the profession in terms about, you know, personal safety and personal safety equipment.
Thanks, Brett. I think that's a very live question, and certainly last week we spoke about PPE a lot, and I'm sure we could run a whole webinar on it. There is a question, and I wonder, Brett, if you'd be kind enough to unpack this, just to tell us a little bit more about what STS is and how health workers are vulnerable to that.
Yeah. Okay. So I think that, you know, let's unpackage the typical symptoms. There's the kind of three symptom categories. So if you place yourself at the front line, and if you place yourself in accident, emergency or intensive care, some people will get re-experiencing phenomena. So some people will feel fear, and then when they're not there, like they're at home or some other time, their levels of fearfulness will be maintained and it'll be very high. So it's almost like being fearful even though you're not in the kind of place of fear. And little triggers like thinking about the hospital or putting on your clothes or getting in the car to go to work will bring that fearful state, that feeling state back to you. So they have re-experiencing phenomena, and in PTSD, that's seen as flashbacks, that kind of thing. So, you know, reminders of the event, or they come suddenly without reminders, you'll get re-experiencing phenomena. Another kind of...
Sorry, Brett, someone's made me laugh very much. STS, they wanted, is that the Society of Thoracic Surgeons? What does it actually stand for? So the
secondary traumatic stress.
Yeah.
Secondary traumatic stress.
Sorry, now keep going, yeah.
Look, the second type of symptoms you get with that is a lot of people spend all of their energy blocking out their emotions. So they force out emotions and force out emotions and force out emotions. And when I was a very young practitioner, I would see these Vietnam veterans and their wife would say, he went to Vietnam with emotions and he came back without emotions. He actually didn't have emotions because you spent all your time being so controlling of your emotions that you actually stopped feeling. And people describe feeling emotionally numb and detached. Now, if you run into an intensive care physician or an A&E person who in a month's time is emotionally numb and detached, they're probably experiencing secondary traumatic stress. And the third symptom constellation is you have ratcheted up your autonomic nervous system. So you've got increased pulse, palpitations, increased blood pressure. You might be hyperventilating. You might be clenching your fist or clenching your jaw. You know, you might have classic symptoms, you know, physical symptoms of stress. So just the three again. So re-experiencing a feeling of fear, emotional numbing and detachment, and all those typical biological stress systems. That's secondary traumatic stress.
Thank you, Brett. And that segues quite nicely to a question that had been sent in prior to tonight, is how do you nudge or support colleagues to seek help who don't think they need it, but are clearly demonstrating signs of stress or anxiety?
Yeah. Wendy, if you don't mind, I might field this one, if that's okay.
No worries at all.
Look, I would encourage people, I mean, there's a new organisation which has appeared very spontaneously and has, you know, a lot of Australian, you know, mental health people and physicians and others involved. It's called Hand in Hand. So it's just spelled, you know, HAND-N-HAND. There's a Hand in Hand COVID-19 Facebook page. There's also a Twitter account and an Instagram. And Hand in Hand is about peer support. And it's about providing peer support. You can actually contact Hand in Hand. And if you want one-to-one peer support or group peer support, they will actually provide this to you. Now, the great thing about Hand in Hand, it's preclinical. You don't have a Medicare mental health number. It's not going to be on your electronic medical health record. It's also free, by the way. And it's about people, and it's a wonderful way for mental health informed GPs and psychiatrists to volunteer to help some of our frontline workers. So you can contact that Facebook page and they will ring you up and ask you what you need. And it's again, it's a preclinical peer support, which of course a lot of our subspecialties don't have peer support. Now, the next thing is if you feel, you know, don't forget, you know, doctors, let's face it, I'm a doctor, so I'm going to talk about us here. We're hopeless. A lot of us don't have a GP, all right? You should, if you are a doctor now, you should, and you don't have a GP, you need to have a GP. And you need to go and see them if you're feeling, you know, burnout, if you're feeling compassion. Everyone knows what compassion fatigue is. If you've spent your career feeling, you know, really very supportive and caring for your patients and you stop doing that, that is not normal. That's not age. That's not aging. That's not normal. You go and talk to your GP or talk to Hand in Hand about it.
Thank you, Brett. I am aware of the time, so I'm going to move on a little bit. And I don't know whether you or Wendy are best placed to answer this. Are there any validated tools or questionnaires which can be used to help frontline healthcare workers track their risk for STS or burnout? And what interventions would you suggest for healthcare workers to manage this?
Over to you, Wendy. Measurements.
I think we have the professional quality of life, the scale. That's what we used in our study. And yeah, that's available. It's a free scale available. You just search professional quality of life, and then you can use the scale to measure 3 components.
And that has burnout and compassion fatigue.
Yes.
And don't forget all those people out there, GPs have been happily and very gainfully, you know, giving the K10 to patients for years and years and years. You can fill it out yourself, about yourself.
Yes, and also another is CASS, I think for the depression, that's a scale developed by Australia. That's the depression, anxiety, and stress scale. 21 items, only 21 items, the reliability.
So what you're saying is that we use the same tools that we give to our patients. They are applicable. Good. Just a couple of comments as well. You were talking about Hand in Hand, but as you know, there's Doctors for Doctors as well. And there's the GP helpline. There's several free helplines as well.
Yeah, and there's the state, you know, every state in Australia has a service just for doctors.
Yeah.
And don't forget, you can pretend you're not a doctor and you can ring, you know, the new Beyond Blue COVID support line, and you can do all of those things.
Yes. So shall we get the slides and then we'll come and finish some questions. We've got about 15 minutes to go. I think this one's...
Oh, sorry, that's for me, that's for me.
Yes,
okay.
that's you.
So, I mean, this is just a little wrap. I mean, we actually do know a lot about disasters, and I think that actually tells us something about what's going to happen. And, you know, the bad news is I think we have, you know, 12 to 24 months of things being problematic. We know lots and lots about the risk factors for PTSD specifically, and that's about threat. And hopefully we won't go down that path. I think there will be a lot of depression and anxiety. And, you know, the burden of illness in mental health generally. And of course, you know, I think general practice sees much more depression than psychiatry does. I mean, the burden of illness will be shared around a lot of professions. I think we need to start preparing ourselves for the economic recession, depression. You know, preparation is actually good, and there are things that we can do. We can think about how we're going to treat, you know, large numbers of people. We're going to think about patients who are unemployed are going to be much more at risk, and especially, you know, people whose whole identity is based in their work, and now they don't have work. We also know that, you know, house repossessions and those kind of things, and in other countries, you know, homelessness goes up and that sort of thing. These are all clear indicators that person might be depressed and might be suicidal. So I think we just need to all prepare ourselves kind of emotionally and as a profession that after this heroic phase, there's plenty of work that we're going to be asked to do.
Thank you. So what I might do then is come to the rest of the questions that were submitted, if they haven't, if people feel they haven't necessarily been covered. So in no particular order, how best do we support patients who already have a significant background of trauma from further trauma as a clinician?
So I do a lot of work with trauma, and one of the problems is that a lot of the, you know, a lot of the the responses to trauma are learnt. So if you've learned to dissociate, I mean, another traumatic event can make that much more likely. Also, you know, when you're traumatized, you often have your innate coping is often less than adequate. So for instance, traumatized people are much, you know, more reticent to reach out. They're more reticent to help seek. They feel that they're abnormal and they're, you know, they're inadequate, all those kind of things. So we need to be highly encouraging of people. And I would have a check-in strategy. If there's people on your books that you have been, you know, subject to domestic violence or sexual abuse or physical abuse, I would actively check in. And I would actively suggest that this could be a very hard time for them. And that is completely understandable. It's a hard time for everybody, but it could be a specific hard time for them. They might be turning to things that aren't helpful, like alcohol, marijuana, that kind of thing. They might be taking, you know, doing risky behavior, which is not helpful. And, you know, there's really good treatments that we can do. But the first thing is to motivate people to engage in getting help.
Thank you. I'll just unmute myself there. And I think this is a related question, which you did touch on. This person has said, how do we effectively manage suicidal risk in complex trauma patients in isolation, they're in quarantine or self-isolation, social distancing, when the crisis care system is already at capacity?
Yeah. So unfortunately, you know, some of these are things that we've never, ever had to deal with before. By the way, I think a word of hope. I'm saying a lot of negative things here, by the way. I mean, I've talked to my daughter in London more in the last month than I've talked for years. It's been fantastic. And here we are, 104 people on Zoom having this kind of interaction. I don't see why we as professionals can't be now, you know, getting separate email accounts and separate phone numbers and ringing our patients and FaceTiming our patients. That was not a product endorsement, by the way, or somehow connecting with our patients or Zooming our patients. I don't see why we can't jump on the technological bandwagon. And I would be, and this is a direct anti-isolation technique. I mean, you know, we know that in mental health with our chronic patients, we have a lot of do not attends. They would probably attend if you talk to them at home on some technology. So seeing our patients that way, involving our patients in groups online, involving our patients in activities online. I've never seen so many gym classes, yoga classes, art classes, and families singing The Sound of Music that I've ever seen before. You know, so I think we just have to be much better at using technology to become socially connected, and that's with our patients as well.
Thank you, Brett. I think you both covered the impacts of COVID-19 on acute mental health presentations, and what I took from it is that our view at the moment is because of the success in flattening the curve, what we're likely more to see is in Australia is recession effects. And there's a lot of evidence around that. And you spoke earlier about the suicide, depression risk. Would that be what, as health professionals, we need to be watching out for, Brett, over the next 6 to 18 months, do you think? Is that?
Well, and I'd also be interested in Wendy's view about what the experience in Wuhan. I think the other issues we're going to have is chronic low-grade anxiety. So, for instance, we're creating a differential between us and other countries. So a lot of other countries will have, you know, endemic rates, high rates, and Australia might have a lot. So we're going to be, you know, concerned about, you know, getting our own little personal, you know, pandemic, because Australia, until a vaccine, will have very little, if none, herd immunity. So I think there's going to be chronic low-grade angst amongst all Australians for a long time. But the really active things, I think, are probably more likely to be recession-related. But don't forget, at the moment, a week is a long time. You know, things can change. So Wendy, I was wondering, I mean, are people in Wuhan concerned about a second wave, or are people, you know, do they still have major anxiety about COVID-19?
I'm not very sure, because when I talk about the second wave, it seems people are not very worried about that, because they believe the government has done a great job in controlling the first wave. And also, it's very interesting. I do agree we need to monitor the long-term impact on mental health. For example, I was very lucky, my team was very lucky, because we collect data among a group of universities before, in late November last year, before the pandemic. And we were lucky to collect another round of data during the pandemic, during the lockdown. That's in late February and early March. And we absolutely expect that the mental health would be worse. But very, very, very surprisingly, we found during the pandemic lockdown, actually the participants' mental health improved. The mean score of their stress, depression, and anxiety significantly reduced. So it's very, very interesting. But when I look at the disaster model Brett presented, I think maybe people still in the heroic stage. And also, yeah, when people collectively fighting something, we feel we are doing very well. We are excited for with what we are doing. So we are planning to collect data after 3 months, and then after 6 months to compare to the previous year. Of course, another argument we present is pandemic is fearful, is stressful. Maybe for Chinese students, academic is more fearful, more stressful. So I think it's very,
students, yeah.
Yeah, so I think we need to be aware of the long-term impact to follow up to see what happened for those this group of participants.
And there's a lot of country-to-country effects. I mean, Chinese people, you know, are used to long, cold winters and might be much better at containment than Aussies who have no tradition for staying inside. So, I mean, these are interesting things, aren't they? Mm.
Yeah, absolutely.
A question then from the audience, a live question is, some simple strategies, briefly, that health professionals can use to reduce risks of anxiety and depression.
Yeah.
So I think, Brett, you've spoken a little bit about social connectedness. Okay. You spoke about breathing and reducing impact. Anything else? Yeah,
if I can just say one thing, I think that, you know, people, you know, in disasters, people almost, and it happens with acute trauma as well, people kind of define their lives from when the disaster started. You know, most of us have had 20, 30, 40 years before the disaster, and we had a whole bunch of things which we mightn't have conceptualized as coping, but they actually are coping. So for some people, there are art and creative things, some people are sport, some people are, you know, a whole range of things. And I spend all my time recategorizing people's activity as that is one of their innate coping mechanisms and re-prescribing it, okay? So I would tell people to not be glued to The Guardian, not be glued to the COVID-19 websites, to actually turn that off and re-prescribe what they did for the rest of their life. I mean, they mightn't be able to jog, although some people have managed to jog a long way on balconies, you know, and re-prescribe what you do. So turn yourself off. You're not a doctor 24 hours a day. Turn yourself off and re-engage with your innate coping, you know, or something you've always wanted to do, you know. Now's the time to master Sultans of Swing on the guitar, folks. You know, possible. It is possible.
Yeah. And Brett, you may not be aware, but we've had quite a few problems with Zoom tonight. So some people have only joined fairly recently. There's a question that's come in really, and I think it relates to post-traumatic growth. So
yeah.
The literature suggesting that not everybody with a history of trauma or have a traumatic event are going to get worse. They actually have some coping mechanisms, and that almost talks to what you were talking about just before, wasn't it?
Yeah, I think that the key is that if you develop a sense of mastery, it's a wonderful word. If you, in the face of adversity, if you develop a sense of mastery, then that is often with you for life. You know, if you've survived X, Y, or Z with some, you know, psychological integrity, you are quite capable of having post-traumatic growth. And I think societies are as well. I think, you know, there are societies around the world, and hopefully we're one of them, who will actually understand the benefits of social connectedness, will understand, you know, the benefits of collectivism. And I'm not talking about political, you know, I'm talking about social collectivism. So I think that post-traumatic growth is a wonderful and beautiful thing, and you do often see it. I mean, I remember after the Brisbane floods, meeting my neighbours and finding some who I'm going to call little old ladies sweeping mud off my porch. And, you know, while I was off counselling people, you know, amazing things happen. And you know, post-traumatic growth is a strong possibility.
Thank you. We're nearly out of time. So just a couple of things. And Brett, I know you looked at this question a bit earlier. It was the question about executive dysfunction, and a comment from a clinician saying a lot of people are struggling because of lack of structure, particularly people with ADHD or other conditions that already affect their executive functioning, and combining that with a lack of social interaction or jobs, routine. This clinician felt this was a real problem for quite a few people, and hadn't noticed there was a lot of talk about this in the media or outside some very tight circles. So if you just want to summarize that would be really good.
Yeah, look, I think people don't realize that most people who work, their lives are incredibly structured. And, you know, they turn up at work on time, they do something onto a morning tea, they do something to lunchtime. It's incredibly structured, and they don't realize this, but their life is like that. And consultants know, you know, when you work for yourself, you know that you can't live without structure. So I strongly advise people to, if they don't have a diary, an old-fashioned diary, roll up a bit of paper and actually schedule their day. You know, plan to do something at 9, 10, 10:30, have a cup of tea, you know, 11, 12, and actually, you know, structure and scaffolding is really good for those people who are, you know, are struggling with executive function. And we do this after disasters. We say, try to return to your normal routine as soon as possible. And even if the environment is totally different, even if all around you is burnt or whatever, flattened, you can still have structure. You can still have a school day despite not having a school room. You know, you need to do that. So I would advise people to get their patients to scaffold themselves, to scaffold as much as possible, and to try to really, even at half an hour aliquots during the day.
Thank you so much. We're going to move to a close in a minute. Just a reminder to people online that you will get a copy of this webinar recording. Apologies to people who weren't able to get on. Could we have the next slide, Pamela? Would that be all right? Thank you. So just a reminder that next Tuesday we have got the webinars on exit strategies. So that's going to be looking at emergent therapies and vaccine. As you know, there's a lot of faith that's been put into the idea of vaccination, and that's really good, but there historically have been great difficulties with creating immunizations against coronaviruses. There are 8 or 9 candidate vaccines that are being looked at intensively, and we will be looking at some of that next week. So a big thank you to Wendy and to Brett for joining us tonight. Thank you for all of you for participating, and look forward to seeing you next week. Good night, and thank you.
Good night.